left atrium,
Right ventricle.
right left ventricle,
Left ventricle.
From the left ventricle, we're gonna have the aorta, right? So I just draw it up here. When aorta running up, so I will write number 1. Ascending aorta. Aorta run up to this level. It's gonna curve. And this become
The aortic
aortic arch. So the aortic arch will give out 3 branches. The first branch is gonna be no name. We say in nomine. It means no name. Because at first the physician, the Asian doctor who find out this vessel, he didn't know what is it. So that's why he just say in nomine. So it means no name, right? But later, they know this vessel will supply blood for the head and the arm. So that's why they call it cervical brachial. Alright, so I just go with the original name. Artery. Fourth, and the form, the denominator here is will give out 2 vessels. Number 4, right subclavian. Right subclavian will supply blood for the right arm. And number 5, right common carotid artery. That's about the first branch from the arch. The second branch, can you guess? Number 6, left common carotid artery. And the last branch from the aortic arch. Number 7, left subclavian artery. After the arch, give out 3 branches. Denominate right CCA, left CCA and left subclavian. It curved down and become number 8. What is it? Descending aorta for sure, because it go down, right? So we stop here because we know when they go down, they become abdominal aorta, and that's what we only learned. So from here, we learn from here up. Okay? And now, from the right and left CCA, good morning. From the right and left CCA, you have it. Right and left CCA. They run on each side of your neck. They run up. They will give a bifurcation. But before they give a bifurcation, they're gonna get big. So I just draw one side, okay? Number 9. When the CCA get big, we call it a bulb. And then the bulb will give a that bifurcation. So now we make it complicated. the CCA here on each side, right? Just imagine the cap is the bulb, okay, the bulb, and then from the bulb, it will give out two branches. Neutral anatomy, this means your face, your neck straight ahead, right? So you're gonna see it. One artery, they're gonna run anterior. Okay, they run anterior and they supply blood for the face and the skin, blah blah blah. So this one we call it ECA, external. Just remember, external which means outside, right? So external is supply blood for superficial. So I'm gonna what number already? 10. External carotid artery. And another artery, they run posterior. They run posterior and they go inside the skull and they supply blood for the brain. So that's why, because they run inside the skull, we call it internal. Right? So this is ICA, internal carotid artery. You see, I try to draw the internal bigger because between two arteries. One artery is more important because it's supply for the brain. So that's why it's bigger. So this is number 11. And we have it in both sides, right and left. Now look at this. This is the point difference between right and left. The right CCA here is start from innominate, but the left CCA is start from the arch. That's the main point difference between right and left. One from the innominate, one directly from the aortic arch. And now the thing more complicated. From the right and the left subclavian artery here, we're gonna have another artery. These arteries start from the subclavian. This is we call vertebral artery, right and left. So I just write it 12. Oh. So the vertebral artery, they start from the subclavian. You know, subclavian run horizontal here, and it's curved down to supply blood for the arm, right? They run like this. But from the subclavian, we have two vertebrae. They start from the subclavian and then they run posterior, parallel with the spine right here, and then go up inside the skull, because the basilar artery supply become the posterior circulation for the brain. But we don't have to. Today we just learn extracranial. It means the vessel run from outside the skull. We don't learn from inside the skull, which including the circle villus and anterior and posterior circulation. This too deep for the beginner, so I skip that part. But now keep in mind the vertebral, they run parallel with the CCA. but they start from subclavian and they run posterior. Good. So this is how the circulation gonna go. The blood from the aortic, right? They go up and then they supply blood for all the vessels. So the point, the vertebral artery blood flow and the common carotid artery blood flow always have the same direction because they are the main source to supply blood for the brain. So they have to go up, go from inferior to superior, and they have to go in the same direction. It's important point because a part of the carotid protocol eject for we call a syndrome, triple S, subclavian steal syndrome. In that syndrome, the circulation, the blood flow of the vertebral gonna be go opposite way with the CCA. Okay, so take a note. Vertebral artery and CCA always run in the same direction in normal condition. Extracranial vessel or just carotid protocol. What should we check? We check from here. Which including right and left CCA, both right and left CCA, both ECA, ICA, vertebral, subclavian. We have to check everything. That's including in the carotid protocol. So now, another note, because it's going to relate to how to differentiate between the ECA and ICA later. As we know, this is ECA, right? The green. This is ICA, the pink. I say different like this, right? One anterior supply blood for superficial. One posterior goes straight up to the brain, supply blood for the brain. So this is neutral anatomy, yeah. But we don't scan when the patient head up, head straight. We always ask the patient turn the head when we scan it. For example, we ask the patient turn to the left to scan the right. Ask the patient turn to the right to scan the left. That's what we're gonna do. So now let's look at anterior, posterior. Now ask the patient turn. How it become? Medial, lateral. You see it? In this plan, the ECA become medial. The ICA become lateral. See it? From anterior and posterior, it's going to become medial and lateral. So we should understand this point, because when we scanning, we will angle medial and lateral to find ECA and ICA. But in the real anatomy, it is anterior and posterior. That's the difference between real anatomy and scanning blank. You get it? Here. Lateral, medial. Anterior, posterior. Okay, another point. Here, up, gonna be inside the skull, right? So, from outside the skull, the ICA here have no branch. They only give out the branch when they get inside the brain. But with the ECA here, they have a lot of branches. And the first branch, we call it superior thyroid artery, supply blood for the thyroid. All right. So I just draw one brand right here. So to differentiate between ECA and ICA. Everyone good with this? I'm going to how to differentiate between ECA and ICA. So I'm going to help you. We have ECA here. And we have ICA here. All right. If we look in the transfer or sagittal, and again, now compare about the size, which one is smaller? Tell me. I just draw it, just look at it. Which one is smaller?
ECA.
Yes. So ECA is smaller. I just drew, yeah, right, small. How about ICA? It's bigger.
Big.
And now, which one have branch? ECA have branch outside the skull. Okay, we're talking about the extracranial have branch. This one now for the extracranial. All right. So now we're talking about lateral and medial. So which one is lateral?
ECA.
ICA. Which one is medial?
ECA.
ECA. But we need to put real anatomy too, right? So medial but anterior, right? Lateral but posterior. Make sense? All right. Now, again, ECA supply blood for the skin. So the skin is vital or non-vital. Can you lose some skin?
Yes.
Yes. So ECA supply blood for non-vital. ICA, they go inside the skull and supply blood for the brain. Can you survive without brain?
No.
No. So it's vital or non-vital?
Right.
Vital. So ICA, we supply blood for the vital organ. From this idea, non-vital and vital, as we know, we learn about resistance of the blood flow. Resistance is mean when the blood get to that one organ and that organ resist to the blood or not. Will define that blood flow have high or low resistance. Okay, that's the definition. So now, just say the brain, the ICA, the vital organ. Do we need the brain get blood all the time, or you only need this morning and then this afternoon the brain doesn't need blood anymore?
No.
So, what is conclusion? The brain needs blood, a lot of blood, all the time in your life, right? So because the brain needs blood all the time, so there is resist to the blood or non-resist. For example, this is blood. I'm a brain. The blood come to me. I need you all the time. Come. That's in non-resist. Or, nah. At this time, I almost sleep. I don't need you. Go away. Go to some other organ. So sometimes I resist to the blood. So now tell me, which condition for the brain?
Non-resistant.
Low resistance because they don't resist to the blood. Come, I need you. 24/7. Just 3 minutes without you, I'm done. That's the real thing. Your brain 3 minutes, dead. Right? So we can conclude the blood flow for the ICA is low resistance. Opposite way, the skin. Oh, it's too cold. It's too cold, so I don't need you. All the vessel will wrinkle and the blood go back inside, deep inside, to spare for some more important structure at some time, right? So, what resistance for the ECA?
High
High
resistance.
resistance. So you see, from definition here, we will define the resistance of the flow, right? And from the high and low resistance, it will define the shape of the waveform. So how the shape of the waveform look like with high resistance? I should draw it here. It's easy to see, right? So high resistance here. The high resistance waveform will have very high and sharp peak signal. And then they have very low and diastole. Just like this. That's about the shape of the high resistance waveform look like. How about low resistance? Can you guess? The low resistance will have lower PS and blunted. And then they're gonna have high ED when you compare with the low resistance. So this is how the low resistance look like. Do you see the difference? Peak systolic, lower, blunted, and diastolic, higher when compared with the high resistance. So you need to practice. This is the highest level, because in some case, this is how this chart gonna help you how to differentiate between ECA and ICA. If you see the vessel bigger than other, so you can get, oh, okay, the bigger one going to be ICA, right? If you see some branches, so you know, okay, the branch is going to be ECA, right? Or you can angle medial and lateral to find either ECA or ICA. But the highest level, you don't have to use any technique. You just find one organ, find one vessel, put the postway on it, look at the shape of the postway, and you will know that is ICA or ECA based on the shape of the waveform. So this is the highest level. But you need to earn a lot of experience to get this level. But I want you to get this level, at least in the future. Because you don't have time. Just boom, okay, here. Put the postway on. Okay, this look low resistance. This is ECA for sure. And or put on this vessel. Boom, this is high resistance. So this is ECA for sure. Good. So remember this chart is important. I have charge and transfer, right? So, but we need to make it easy. So I want you scan the transfer completely first, and then we can go with the charge. Why? For example, for one spot only. Okay, I'm talking about proximal CCA. So you go to scan transfer, and then switch to charge door, and then go to mid. You go to transfer charge door. This door transfer charge door. You keep switching the transducer, right? The same with the both ICA, ECA. So it's uncomfortable. So that's why I want you to go transfer completely from block, mid, this door, both bifurcation, completely first. And then we go charge door from beginning up. It's easy for you. You don't have to tweak the transducer back and forth between the shunt or the transfer. That's my technique and my suggestion. But if you feel, I want to follow, this is, by the way, this is my protocol. And I'm so happy when charter college want to give it. So that's why I put the charter college name. All right, so just I'm assuming you want to follow with my strategy. First, we're going to scan transfer. This protocol is long and a lot of new ideas, so that's why I did two different parts. For the transfer, you're going to scan here, it's proximal. In the mid, distal considered just before the bifurcation, before the bulb. This is the distal. So, prox, mid, distal. And then bulb. And then bifurcation. Okay, so for the transfer, we're checking for proximal CCA, mid CCA, distal CCA, bulb, and bifurcation, B mode and color mode. So I just write, how about, you see the prox, mid, and distal is quite simple. You're gonna label it right or left, depend. I just write right, CCA, proximal, transfer. And then you're going to scan the B mode with a circle. And then you hit color. This is requirement for the B mode and color for the vessel when you scan in the vascular. B mode, the lumen of the vessel have to be completely, no, B mode, unequal, completely unequal. So I don't know, you have to use all your technique, all your skill to adjust the vessel lumen unequal. That's a must. And then when you turn the color on, the color have to fill completely inside the vessel, because any spot not filling with the color is going to be special for the calcification, for the blood clot, for the stenosis. That's the reason. B mode unequal, color mode, color fill completely. That's a must for the vessel. So you're going to see right CCA, proximal, transfer, B mode, and color mode. And of course, you already learned about the physics, so I don't want to remind it here because I remind it, it's going to take forever. The color inside the artery here have to be red. So depend on the angle, you're going to see it red or blue. But if you see blue, hit on the invert button to convert the color to red. Okay, so with the CCA or the vessel in this protocol, it have to be red. So red, fill color, unequal with B mode. That's a must. Good. We will repeat this step for mid. It's going to look the same. We start transfer from the neck base right for the proximal, and then we sweep up to the mid neck for the mid. Okay, some hospital they skip the mid, but I want you to do completely because you learn it. So for the mid here, and then for the distal, to define the distal, just like the way you define the distal of aorta, the distal has to be before the bulb, right? So from the mid here, you sweep up, still transfer until you see the CCA get larger. So when the CCA get larger, you know that is the bulb, right? So when you see larger, you pause and you go back to the normal the diameter. So this is going to be considered distal. Yeah. So just like this, you scan mid like this, right? And then you sweep up. You're gonna see it larger. All right. So you stop right here. You see, okay, it get larger. It means this is the bulb already. So you go back to see the same vessel with mid. So this consider distal. Yeah. Keep in mind the calcification, the pathology may happen anywhere when you sweep from the proximal to the bulb. Okay, and this is very important. You know the calcification. They get the stenosis. When the stenosis happens, this means the blood go to the brain decreasing, and that's the reason lead to what pathology? Shock. That's the reason we need to scan the carotid. Right? So this is top, mid, the same, and then distal. And then the bulb gonna get larger. So you get the broad, mid, slide up. Oh, bigger. Pause. This is the bulb. Go back. This is distal. Alright, take distal. And then go backward. Bulb. Take the bulb, B mod and color mod. But the bulb gonna be look different. Why? It's larger and the color different. Because you know the bulb right here is the bifurcation. The flow from the bulb will split. Right? So that's why you're gonna see two color in the bulb because the blood go into different way. One go ICA and one go ECA. So that's why the bulb will look like this. And it's normal. Blue and red together in the bulb area. Alright, so that's a bulb. And then from the bulb here, you go higher. You will see the bulb split to two circles. And that consider the bifurcation here. ICA and ECA. So you're gonna see when you go higher, you're gonna see one small and one big. Based on the side, based on the observation here, can you tell which one is ICA or ECA?
The smaller.
Just side the side.
ICA is the big one.
Yes,
Yeah.
ICA is big. Based on the side, right? Based on the side, the ICA and ECA gonna you can get at least the first idea which one is ICA or ECA, but not always, because the problem is the ICA and ECA position very variable. Why I say variable, especially in the older people, older population. We learn in the book, this is the ICA and ECA, right? Yeah, that's what we learn. I just taught you. Some people, they tweet and they wrap around. So that's why and someone they switch completely, and someone they just before and after. I mean the front and the back. They not go like real anatomy we learn. So sometimes you scan, you see this. They in the horizontal. Sometimes you will see they like this. And sometimes they may switch position. So that's why in the transfer position, we just take and check for the underliquid and the color filling. We don't differentiate between ICA and ECA position. Yeah, they're very variable location. Good. So we get broad, mid, distal, bulb, and bifurcation. 1, 2, 3, 4, 5 times 2 equals 10 picture. Yes, so we do it in both sides, right? So, but I just say one side. So we done with the transfer. Everyone good with transfer? Yes. Broad, mid, distal, CCA, the bulb, and the bifurcation. Transfer. B mod, color mod. Easy. And now, we done with the transfer. You guys good? CCA, charge proximal. So you're going to open the CCA completely off the screen. This is the screen with the B mode. You need to adjust the B mode again to make inside of the CCA completely unable. Okay? In some people, you will see a circle right here. Okay? And this is my experience only. I use this circle like a landmark to separate between proximal and mid. And this circle is inferior thyroid artery. I just use it for myself. Okay, if you want to do it, use it, you can use it. If you don't have to. Alright, it's not in the book. Just experience. Alright, so you open this one for the CCA. You're gonna take the picture, B mode. And then you turn the color on for the color mode. For the color mode, you need to use the angle steer to steer the box. This one. And the color inside going to be red. The color going to be red. So the color mode, after you're done with the color mode, you're going to hit the pulse way on. When you hit the pulse way on, I don't know, this I teach you guys about the angle correction or angle isolation, but it's about the physics. But keep in mind, when you hit the pulse way on, it's going to look like this. How can I draw? Should we join it like this? In here is sample volume, and this is the line. You're gonna see on the bottom here they have the AC60. All right, the AC60 is just angle correction. It's fine. But the point now, this line have to always parallel with the vessel axis. Okay, this line parallel with the vessel axis, so it means you align the angle isolation with angle correction. And the sample volume here equal 1/3 of the vessel diameter. And bring it to the center to collect the signal of the center of the vessel. Not on the wall, not close to the wall, not too big. Alright, so when you take this one, you're gonna see the waveform right here. This here we call the baseline. So for the artery, below the baseline very less signal. So you bring down the baseline down. So this means you don't see this. Okay? And right here you're gonna see like the number. This is we got scale. Physics learning. You can adjust the scale to eliminate the aliasing. So that's why I want you to adjust the scale to get this waveform 2/3 of the scale. It's going to be 150, for example. So this is going to be the good waveform. This distance is 2/3 with this distance by adjust the scale. And then you collect enough signal right here. When you free this machine, they auto calculate the PS and ED velocity for you. You're gonna see here and here. But don't judge the machine 100%. You need to watch. If they measure it wrong, you can use a cursor to adjust the measurement to get the correct position for peak systole and end diastolic velocity. Alright, so when you do it, you good with the velocity, you can hit on the measurement location. So when you hit on it, you're going to see the box right here. For example, we measure the right CCA sagittal proximal. You're going to see right CCA proximal, peak systolic number, and end diastolic number in the box measurement. So when you see this number, you good, you can say. Because this number will go to the report. And with the vascular, this number is the most important. Doctor will use this number to diagnose. Yeah, so we do the same. Broad, mid, and distal. With the distal here, you're going to see the both area. So you have two options. You measure the proximal here. You do the same with the mid. Okay, and then for the distal here, you can angle or you can rock the transducer to get the box steer this way to get the distal in this position. But in some case, I know for the beginner, it's really hard to do it, especially when you rock up one side of the transducer, we push to the patient's neck. The patient will feel uncomfortable. So that's why it's acceptable. If you need, you can adjust the color box. This way, I believe it's going to be much easier for you for the distal CCA. Alright, so we stop here today. Complete transfer. We try to adjust just one spot, try to open the full vessel, try to collect good color and posture before you go block mid distal CCA. It's too much for you already for 1 day. Good. This one, most of the time, I'm gonna give students 8 hours per week in 2 months to finish this protocol. Because you see, we scan a lot, right? CCA, bulb, ICA, ECA, vertebral, supply on both sides. It's a lot. I know.